Welcome to this presentation from the American Society of Echocardiography. My name is Jeff Rose. I'm with the Sanger Heart and Vascular Institute in Charlotte, North Carolina. And what I'd like to do in this presentation is walk through the details of a Qrur report and a PQRS report. These are reports that are generated for us each year from CMS, which is Medicare. And I'd like to convey the relevance of these reports and how they can be applicable to your practice and offer some particular points on their specific utilization. So to begin, what is a Qrur report? This is the quality and resource use report that is produced by CMS each year, and it is how CMS gauges how we practice as providers. So a couple of background points just to understand out of the gate. As an eligible professional, that is as a physician, as a nurse practitioner, as a physician's assistant, and other providers, we have national provider numbers, which is how Medicare knows who we are. Most of us are organized, however, in practice in some form of group setting. And how your group is identified to CMS is known as a taxpayer identification number, or TIN. So what CMS does over the course of the year through billings and so forth, through a very complex method, is attributes patients who have received services and assigns them to individual providers based upon the NPI number, but also ultimately to the TIN, to the tax ID number. And it is on the basis of the performance of the TIN on how CMS determines the value of care, meaning the quality of care that is provided to Medicare beneficiaries and also the cost of care. What we'll do in this talk is walk through how CMS actually determines that. The output of that determination is the Qrur report, which is what we're going to go through now in the next few minutes. So now, why is this important? Well, as we move forward, at the present time, the performance with respect to quality and cost placed together in value is rewarded, if you will, by Medicare in this chart. So just to walk through the blue grid here in the center for a moment, if you're deemed to be of average cost and average quality, Medicare pays you at the base rate. However, if your quality is average but your costs are lower, you actually get a 1% benefit in terms of the physician's fee schedule. In other words, CMS will pay 101% of the fee schedule to you. If your performance is in that upper right-hand corner of both high quality and low cost, then there's a 2% bonus. In addition to this, if the population that you serve is high risk, and we'll walk through that in just a moment, but basically if you're serving patients who are in the highest quartile of risk, there's an additional 1% bonus for performance in this regard. So at the end of the day, CMS is now rewarding on a financial basis and paying a bonus, if you will, for higher value care. So how do we get to this point, and how did CMS make this determination? So this slide from CMS walks through what 2018 will look like. So in 2016, almost 2 years ago, we, all of us, took care of patients and at a certain measure of performance, and in early 2017, that was reported to CMS. All physicians and all providers who actually did that reporting or had their provider groups are on the left-hand side of this picture and are Category 1 physicians. And if the reporting requirements were met by the tax ID number, then the providers in these tax ID numbers would qualify for up to a 3% bonus depending upon performance, which we'll come to. However, for those, for whatever reason, chose not to report during that time frame. Those practitioners are categorized as Category 2 providers. And what will happen January 1st, 2018, is that they will be subject to either a 1 or 2% downward adjustment in Medicare payment for every Medicare claim throughout calendar year 2018. So that's a pretty substantial impact on revenues coming back to the organization. So this underscores the value of understanding these programs and having participated in them. So as we go forward, the first question that comes up is, well, who is in my tax ID number? Who does Medicare think I'm practicing with? How does this all work out? And this comes back in the PQRS report. At the end of this talk, I'll walk you through how we actually get these reports. They are online, and representatives from your organization can obtain these reports. But for the moment, let's just accept that these are reports that are available to your organization. In this slide, I have blanked out the NPI and NPI name on the left-hand side for privacy purposes, but you can see that in the third column, the provider specialties are outlined, and there is a list of all the Part B physician fee schedule charges that that provider had to Medicare for the calendar year. There are a variety of other columns here that walk through various adjustments and qualifications and so forth, but this is basically the list of all the providers within the specific tax ID number. Once we have established who is in the tax ID number, then we can begin to look at, well, what actually was reported. And this slide shows this as well. This goes through the various quality metrics that were selected by this particular tax ID number. At the bottom of the page, you can see that controlling high blood pressure, for example, was one of the quality metrics. You can see the number of encounters and so forth. So this is how quality is assessed or reported, rather, with respect to PQRS, the Physician's Quality Reporting System. This tells us in this slide, again from the report, what was measured in terms of the methodology. It is important to know that within the PQRS system, there's a variety of ways that the data that are produced can get to Medicare. One way is through claims, which is just through billing data that Medicare has. A second way is through submission, and that is where, from your electronic medical record, representatives from your organization report specific data to CMS. A third would be through a qualified clinical data registry. So, for example, those who participate in the American College of Cardiology's Pinnacle Registry, that would be one way for data to get back to CMS in terms of group's performance. So the PQRS begins by just providing a feedback tool to your organization about what information does CMS have, who it is being ascribed to, and sort of the quality of the data reporting, not yet the performance, but just the fact of, did we get the data where it needed to go? While this is reported out on the level of the entire tax ID number, through the various tables, individual performance can be ascertained as well, as denoted here by the arrow. What's interesting, CMS also provides a list to organizations that will provide data that CMS has available through claims. So for an organization that is determining what to report on a specific year, important feedback comes back to CMS that will tell the organization for each provider what claims data were available for an individual provider. So in this specific example, under PQRS measure, the last one, measure 204 for ischemic vascular disease, in the domain of effective clinical care, there were 3 measures that could have been used for this particular provider. So again, feedback for the quality department at the organization to take a look at what data are out there in terms of claims-based data if the organization chooses to report in that specific domain. So the PQRS report really tells us who is in the group that's being looked at, who is in the tax ID number, what their specific billing dollars were, if you will, and then also what was actually reported to assess quality over the given year. So that's the PQRS report, and that forms the basis of the output of what this is. And this is the Qrur report. And what you can see here in this particular grid, if I can draw your attention to the center, you see a XY grid of quality and cost. And each of the blue dots that you see represented on this slide represent individual tax ID numbers across the U.S. In the example highlighted in red, where it says U, for this particular tax ID number, those who were part of this group were deemed to be, as you can see from the grid, to be of high quality and low cost relative to their peers. So the sum total of their performance in 2016 is reflected in 2018 by this measure of performance. And we'll walk through how CMS came to this conclusion as we move forward. Before going forward, though, an important element here is CMS will risk assess the patient population, and this is based upon claims data. So, for example, in this group in the tax ID number, they had strong quality and cost performance. However, their beneficiary risk was at the 38th percentile of others in the nations, which means that according to Medicare, this particular, the providers in this particular tax ID number were taking care of a cohort of patients who were statistically less sick than the mean across the nation. And this has implications with respect to risk stratification. In addition, for those tax ID number providers who are taking care of patients who are in the 75th percentile or higher, the bonuses that I showed you before of 1% and 2% are actually increased by a percentage point. So makes a real difference here with respect to the cohort of patients that people are taking care of. Again, this is all determined by claims data. So we'll come back to that at the end about how we can take a look at that a little bit more carefully. So coming back to the example for this particular tax ID number, they were determined to be of high quality and low cost. So they will be rewarded in 2018 with a 2% bonus on the physician's fee schedule, meaning they'll be paid 1.02% of the fee schedule. Had they been taking care of a cohort that was even sicker, meaning in the 75th percentile or greater, then they would have achieved a 3% bonus. So that's the mechanics of the Qrur system. So the Qrur is quality in the numerator and cost in the denominator. So how does CMS arrive at these values? Again, walking through this particular example, in the Qrur report, in the second exhibit, it will walk through the methodology in a fairly straightforward fashion. So for this particular group, they had a composite quality score which was greater than 1 standard deviation better than national peers. Their score was 1.32. Thus, they were deemed to be of high quality and in that upper right-hand quadrant that we showed. How did they get to the 1.32? Well, it comes from a variety of data sources. Important in the quality composite score is the performance in the PQRS measures that those in the tax ID number submitted for the calendar year. So there are a variety of measures of performance that are accepted by CMS. So, for example, blood pressure control within a population, use of aspirin in patients with ischemic heart disease and the like. And organizations will choose to submit those quality measures that reflect their performance, and typically they will submit measures in which they excel. And that data is available through the Qrur report so that organizations can reflect back and do a cross-check on the data coming out from their organization back to CMS. However, in addition to the data that an organization chooses to send, there are also other inferences on quality that CMS is able to obtain through claims-based data. And these are also outlined in this slide and available through the various tables in the Qrur report. So looking at the beneficiaries that have been attributed to the tax ID numbers, CMS is able to make inferences from those claims data on performance with respect to quality and outcome measures. It's the combination of those measures plus the reported measures that ultimately lead to the domain score. So you can see in this example, controlling high blood pressure, the performance in this tin was in the 70.57 percentile, where the national benchmark was 62.69. So in this particular tin, the providers, according to CMS, were doing a better job in controlling high blood pressure than national peers. And from this type of performance, a quality score is ultimately able to be derived. So in addition to the cost, the quality, which is reflected in the numerator, in the denominator is the cost score. In this example, this particular tin's cost was low, was greater than 1 standard deviation lower than average cost nationally. So again, that combination of high quality, low cost is what ultimately resulted in the 2% bonus for this particular group. So how is cost determined? And this is predominantly determined by a combination of episodes of care and also total spending per beneficiary. So you can see in the top of the slide for calculating composite cost, there is a combination of per capita costs for beneficiaries, per capita costs for beneficiaries with specific conditions, and you can see diabetes, COPD, coronary disease, and heart failure are reflected here. And then there's also Medicare spending per beneficiary, and that reflects the costs for specific episodes. So aside from all-in costs for the entire year on the per capita costs, we also have episode costs that are factored in from Medicare through their methodology by which they determine the length of an episode. These reflect costs from Part A and Part B. These are not just the provider costs, but these are all-in costs for the individual patient. At the lower part of the slide, you can see that as these values are calculated by CMS, they ultimately come together to form a composite score. And in this particular example, the composite score was greater than 1 standard deviation less than the national mean, which resulted in the bonus that we saw previously. So as we're looking at costs across the tax ID number, I want to call your attention to two specific areas that I think are particularly relevant to us as cardiovascular providers. They're the per capita costs for beneficiaries with coronary artery disease and those with heart failure. And from the report, we'll be able to actually look at those categories of care, and it allows us to then go back to look at our attributed beneficiaries and really do a deep dive at, through the electronic medical record at our home institutions to see where our opportunities are to improve with respect to those domains of care. So, highlighting that a bit, if we go back and look in a little further detail, you can see here in Exhibit 7, here's one bit of the information that was used in calculating this particular TIN's composite costs. So if we look at the cost measure, per capita cost for all attributed beneficiaries, in the yellow arrow, you can see that the per capita cost was $5,587, whereas the national benchmark was over $12,000. If we look at Medicare spending per beneficiary, which is really episode costs, 3 days before and 30 days thereafter a specific event, the costs were $16,000 roughly for this tax ID number, whereas the national benchmark was about $20,000. So you can see in this example, this particular group of providers were able to deliver care at a much lower cost than national benchmarks. And as a result, this element of their cost composite score was significantly lower than 0. Remember, anything lower than minus 1.0 qualifies for a bonus. So this particular group was high performing with respect to the cost of care determination. So how do they get to be so good, and where do they excel? And this is where the report really gets into a tremendous amount of detail. This is just a outline of all the tables that come with the report to allow organizations to do a deep dive into their own specific data to see where their areas of excellence were, for example, the various domains of care. So if we just walk through some of those tables in the next few minutes, the first table just goes through and gives us a list of the eligible providers within the organization. I would like to highlight one specific point, and that is about midway through the columns, you can see a column that says specialty designation. And this is a very important column because this is where CMS has actually made a determination if a given provider belongs to a specific specialty. So this becomes important from a benchmarking standpoint. For example, internal medicine physicians are benchmarked against internal medicine physicians. Cardiologists are benchmarked against cardiologists. Within cardiology, electrophysiologists are benchmarked against electrophysiologists, and so forth. So you can imagine an example where an electrophysiologist, who is both a cardiologist and an internist, a specialist in internal medicine, is classified as an internal medicine physician. He or she would look extraordinarily expensive to CMS because most internal medicine physicians are not attributed with patients who have the same degree of cost that your typical electrophysiologist would have because of the type of work involved in electrophysiology with implanting devices and so forth. So this designation becomes very important for us to cross-check. Again, the only way Medicare knows who you are or I am relative to practice are through these specialty designations. And these are submitted to Medicare on behalf of our organizations, but in the bureaucratic world where we all practice and so forth, it's not surprising that sometimes the classification isn't always right, and there can be significant implications to this. So again, getting the specialty designation right, or making sure it's right, is important from an organizational standpoint. Once we've gone through and we know who the providers are within the tax ID number and what their classification is, this slide where I've blanked out pertinent detail gives us a list of all of the beneficiaries who have been ascribed to the tax ID number for the year. It also provides in the center area of the table which eligible professional in the TIN billed the most primary care services. Next to that, who billed the most non-primary care services, and so forth. So you can see you have case level detail provided to your organization about those patients that are being evaluated in the QRUR report. Next, once we know who's in the tax ID number in Medicare's eyes and which patients have been ascribed, they now are able to provide us with data on per capita costs for all the patients in the tax ID number. So you can see for all the patients who are attributed how one particular tax ID number performs relative to another with respect to costs and national benchmarks. And this begins to afford opportunities for improvement in care. Listed down along the table, not only are the evaluation and management services, but ancillary services, hospital inpatient services, emergency services, and so forth. So again, benchmarking against national peers is available through this table. This is also expanded even further to case level detail. So we can see in this particular example how sick the patients were deemed to be. Next to the blue box, you'll see something called HCC percentile ranking that tells us how ill our patients are with respect to comorbidities. You can see the conditions that they have and data then available in terms of the various spend for these patients. And with these data, organizations can begin to do deep dives, looking and seeing whether the provider was taken care of by a particular subset of providers, for example, a hospitalist versus cardiologists or internal medicine physicians. There's a lot of opportunity here for understanding how care has been provided and what the opportunities are. As we build upon that same framework, you can see in this next slide, even more detailed, this is the per capita costs for patients with coronary artery disease. So again, the same methodology that we saw previously, which was for all comers, now we're getting more select data around cardiovascular specific diagnoses. And again, performance at the 10 level versus performance of national peers and benchmarking data readily available. Table 5 gives us Medicare spending per beneficiary. As I mentioned previously, this is really around episodes of care, so not the entire spend for the year, but really around a more discrete episode or hospitalization. And again, this also gives a specific breakdown as to the various domains of cost and provides an organization an opportunity to see where they benchmark. For example, utilization of post-acute care. Where does an organization, what percentage of the spend is apportioned to that domain might be a relevant area for an organization to take a look at, as well as inpatient spending. So through these reports, we get considerable data to how the quality of care we provide is assessed, and also how the resources we utilize to provide that care, or the cost, is assessed. And it's reflected in the QRUR report. This slide provides some information on how an organization can access the QRUR report. I'll begin by saying that it's not something that you or I can just log on and get. Representatives from the organization have to have registered with CMS to have access to these data. This is done by setting up a specific identification account, and this slide provides a reference for how that is done. But most of us who are practicing in large healthcare organizations, there will be somebody in your quality department or part of the administrative infrastructure of your organization who is already registered and has access to these reports. In conversations with colleagues, I find more often that while these reports are available, they just aren't making it back to the management side of the practices. So I would really encourage you to be asking in your organization for access to these reports and begin to have an opportunity to dive into the data and into the detail. If upon doing that, there's disagreement, you find providers in your tax ID number who aren't in your organization or other areas of concern, this can be appealed back to CMS. These reports came out about 2 or 3 weeks ago. Any reviews that organizations would want to have performed by CMS have to be requested before December 1st. So this is something that it's important at an organizational level to get to those reviews, particularly if you feel that the output of the Qrur report for your organization was incorrect. So a lot of information in a relatively short period of time. I recognize that this is a fairly complex topic. What are some of the simple things that we can do going forward to begin to understand this? So first off, as I mentioned, obtain the report and begin to review it. We should be doing that now because if there are any concerns organizationally, those have to be submitted by the end of the month. So that's going to be an important task. When you do have the data, I would really encourage members of your organization to look specifically at your performance on those patients with coronary artery disease and heart failure, because I think that's where you'll find opportunities to improve the care delivery. You may find that you are higher utilizers of post-acute care for your heart failure patients. You may find that your inpatient services, the spend is higher for heart failure patients when taken care of by a hospitalist group as opposed to a cardiology member. So these are the kinds of information that you can begin to get from the data sources. The last point is one, though, that I think deserves special mention. And you'll recall from the example on the slides earlier that this particular tax ID group was caring for a population of patients with relatively low risk score with respect to overall severity of illness. And again, that assertion is really made by claims data. So if your organization doesn't have a comprehensive system for really assessing through the billing data and reflecting with some degree of specificity the various diagnoses that the patients that you're caring for actually have, your patients are going to look to be less sick, if you will, than your peers. So for example, patients who have unspecified heart failure are not classified to be as sick as those who have chronic systolic and diastolic heart failure. So this is where the coding aspect comes into play. And details of that are beyond the scope of this presentation, but I just want to highlight it to you that these billing claims data are critically important for this aspect of risk stratification. And as we close, I think it's important to emphasize a couple of things. Number one, ASC advocacy has been very engaged in this space. On the Connect ASC website, you'll find more information on this topic, as well as links to other resource material. So I think that that's important to recognize. Number two, what we've just discussed in terms of Qrur reporting and so forth, this is the final year for this, 2018, as I hope most on who are listening to this presentation recognize that in fiscal year 2019, we'll move into MACRA, and most of us will be in the merit-based incentive payment system, which is quite similar, although there are differences from this PQRS system, but the same principles hold true about reporting with respect to quality, about benchmarking from a CMS perspective, and about risk stratification from claims data. So those things are all important in the macro environment as they have been with respect to our current environment of PQRS and QRUR reporting. So I'd like to thank you for hanging in there and listening to this presentation. As I mentioned, I know that this is not necessarily the most easy bit of information to digest. It can become fairly complex, but I think if you take it in small chunks and take a look at the bits of information that are available, there's actually an opportunity here for us to provide a greater value to our patients in terms of the care delivery. So thank you very much for your attention.